Hi, good evening.
Good evening.
Welcome. Thank you for joining me. I'm Dr. Maria Sophocles, and if you're watching Gynecollege. And as those of you who've seen other episodes know, this is a short, quick, but sometimes deep dive into issues that impact women and women's lives and women's healthcare. Among those issues, and one that's been increasingly revisited in the past year, is that of healthcare disparity among or between races. The coronavirus has highlighted this. This is not a new issue. This is something that's been well known, especially in the Black community. But with increasing deaths from COVID and a disproportionate number of deaths in the Black community from COVID, I think it's important to re-look at this very old and ingrained problem. And joining me tonight are two colleagues, Dr. Africa Wallace, who's the Director of Thoracic Surgery at Capitol Health Medical Center, and Dr. Jessica Codjoe, who's the Divisional Director of Hospital Services, and not to mention a mother of five. And both are joining me tonight so that we can have an informal but important discussion. And as I hope you all know who are watching, you're welcome to ask questions. You can ask questions while we're speaking. You can ask questions at the end. It's just 30 minutes. And we look forward to a good discussion. I'm going to actually start by just giving a little bit of background into my unfortunate exposure to racial disparity in women's healthcare as an OBGYN resident in Baltimore in the 90s. I was living and training in a city with the highest teen pregnancy rate, and it was disproportionately affecting the Latino communities and the Black communities in Baltimore. And I was delivering baby after baby to 12-year-olds and 13-year-olds and 14-year-olds with grandmothers who were 15 years older, and they would be back 9 months later for another pregnancy. And it was it continues to dog and to plague, especially communities of poverty. So I guess this is not saying anything new, but that to me, the disparity in healthcare, the racial disparity in healthcare is simply an expression of a racial disparity in access to healthcare, and another example of structural racism that's so endemic. So I'm sure that's going to be obvious. The statistics are frightening. They're frankly embarrassing for a first world country. Black patients are 3.7 times more likely to die from COVID than white patients. Black moms are 1.5 more times likely to have a preterm delivery, 2 times more likely to suffer from maternal morbidity, and 3 to 4 times more likely to die from childbirth complications in the United States of America. This is not in a third world country. This is in our country. And these statistics are when we adjust for age, and we take out any confounding variables we can. These statistics are across socioeconomic barriers, which I find even more stunning. That a Black woman with a college or graduate degree can still have an increased risk of a pregnancy complication in this country today in 2021. And I know, Africa, as a cardiothoracic surgeon, you've, I'm sure, crossed paths with pregnant women that you've had to operate on, or problems with pregnancy, and seen this, Jessica, you too. So I'd love to hear from you. I'd love to hear what your personal thoughts are about the topic and about how it may or may not have evolved. And then I'd love to talk in our brief time about what might be some important things that women watching today could leave tonight with, that they could do literally tomorrow in terms of advocating for their own health care, or if they're clinicians watching, how they could help in their own way move the system forward, move the ball forward. Dr. Wallace, can we start with you? Do you have
Sure. So, historically, Blacks have been at the worst intersection of health and social factors, such as economics, with higher rates of unemployment, higher rates of job loss, lack of access to quality education. And this affects the ability to really have favorable outcomes, both in the country and the world. I actually got interested in cardiovascular disease because even as in college, when I was in the research lab and subsequently in medical school, I couldn't understand why Black people had higher rates of high blood pressure, diabetes, all those disease processes that was not explained by genetics. And so it became a question of there has to be something more than just because we're Black that this is happening. And I think what is as you talk about it crossing socioeconomic and educational lines now, I think what it speaks to is that this is a systemic and structural problem. And so it's great that COVID is highlighting these things. And Dr. Codjoe, I'm going to pass it on to you. But it's great that COVID is highlighting one of these things, but I think this has been happening for years. But I appreciate your willingness to have this conversation now and have it on your platform.
Yeah. Well, we all treat women, in our own way, of all ages, races, ethnicities, religious backgrounds. And I think it's another manifestation also of cultural competency, which when I trained in the 90s was barely addressed at all. I'm hopeful that it's taught more now, but I don't know. Studies have shown recently that there is so much bias among most practicing clinicians today. So I think that's one level where maybe we have to start at medical education and just give it the importance it's due. And you think there are, I've read training programs and websites that clinicians can go to almost take like a little quiz to see if they have bias. I think part of the problem is they don't, so many physicians they feel that they're educated and they're not biased, but it shows, studies show there is a lot of bias at the clinician level. Have either of you come across that?
Yeah, I think that there's certainly bias across every level. So physicians are people, right? And I think that sometimes we think that we are somehow above the normal population, right? Whether, we think we're superheroes in terms of our own health. And we also went into this to serve the greater good. But the reality is that we're all people, right? And so we all have our own biases. And at the end of the day, if you can't own the fact that you have a bias, you're going to miss the ball in terms of taking the first steps to get that better. I think dovetailing on what Africa was speaking of systemic bias that has been occurring through the generations within this country for Black Americans in particular, but then, subsequent to that to other minority populations. When COVID started for us, everyone was scared, right? Like everyone was terrified. Everyone hunkered down and went to their house and locked themselves up. And if anything should be a disease that's not biased, it's a pandemic, right? And so a pandemic should have hit us evenly. And, I remember early on being like, it's really weird. It seems like everyone is Hispanic, and you start to see, could that be? Is it that we're really starting to see that? And the reality is that that's what was happening, right? Is that Blacks and Hispanics, for many of the social determinants of health, the things, everything that Africa is alluding to, from, literacy rates to access to healthcare throughout their entire lives, to birth rates and to young women having children. And, when you start piecing that all together and a pandemic hits, and then then it smacks you in the face, right? Because you can't ignore that statistic. You can't ignore the statistic that regardless of the fact that, we make up 30% of the population, we're accounting for more than 50% of COVID, and we're accounting for far many more deaths than the rest of the population. That doesn't really make sense. And so then you have to start thinking it's, exactly what Africa is saying. This isn't just about, our genetics, right? That doesn't really just explain it. There have to be so many other factors that are at play there. And, until we're able, if I have to think of the good that came of COVID, if we could say that there was good of COVID, the good that came of COVID is that it really highlighted for us in a meaningful way that there has to be change, right? That this status quo, we cannot pretend that this is really nothing. And we can't sweep it under the rug because it exists. And the only way to really be able to have meaningful change is to acknowledge it and then say, okay, we have a problem. What are we going to do with it? How do we really untangle the mess that we've gotten ourselves into? Because, I think when you think about women's health, there are biases just by gender that allow us to ignore the disparities in women's health, right? And that's the reality that, I think we don't like to talk about, but that's the reality, right? I don't know how you can have such alarming differences between Black women and white women and not realize that that's a major issue.
Right.
So I think that the benefit or if you can, the positive of COVID would have been, for me at least, that it highlighted for us in a really meaningful way that we are struggling as a nation. And to take that a step further, I think having the things, having George Floyd and having all of those issues kind of play out when everyone was trapped at home,
Right.
really allowed us to see, wait a minute, we have worse outcomes, and then this, and so, my hope would be that is at least the catalyst to allow us to really make meaningful change this time, right? Because change should have been made all along the while, but.
So I think change has to come at several different levels. I think it has to come individually and personally at a clinician level, for sure, so that every clinician who walks into an exam room or an operating room or an emergency room or a hospital room can somehow know that they have to apply their knowledge of evaluation and diagnosis and treatment equally, not somehow there's some little switch that seems to get hit, because we know that women of color receive less pain medication than white women. This doesn't even make sense to me.
Right.
We know that there's a difference in the test orders. We know that there's a delay in care. So that has to come at that level. But then, of course, there's a policy level, right? There's public policy algorithms for spending and things like that. And this is where I don't know if it's our national societies that need to be involved or lobbying, but certainly there has to be at a national level acknowledgement of this so that there's better access to screening and preventive care.
I think, sorry to cut you off.
No.
I think it's all of the above, right? I mean, I think it has to start on the individual level. We have to educate ourselves. We went into medicine to help people, and I would only assume that we're all well-meaning, but we all have biases. We all have biases, and acknowledging them, trying to mitigate them when you are involved in patient care. More importantly, speaking up when you see unfair practices in your institution, and then coming together and trying to dismantle that system. In a way that you have not only, in a way that you can bring providers together, the entire institution, to look at what's happening and decide to make a change. But, so it really does start with the individual, because if you don't acknowledge it in yourself, then how are you going to make policies that are fair if you haven't acknowledged your own biases? And then, of course, the national societies and organizations have to be involved. So I think there, like you said, is on multiple tiers, but you really have to start with yourself and change, and then your peers, and, hopefully it will become a movement.
Yeah, and I think also creating things, there are workups, right, that it's standard. And, I think being able to leverage things like AI and be able to leverage technology there are standards of care that should be met. And so It really shouldn't be based on the color of your skin, what types of tests that you're getting done, what types of workups you're getting done. There are algorithms that we can easily use. But then having a mechanism to look at that and to say, well, that's interesting. If I go back and look at this, your workup was this way for this patient, right? And it was different on this patient. And then starting to deconstruct that and figure out what are the differences there.
Yeah.
It's something. I'm Puerto Rican, so I feel comfortable saying it. I think that one of the things that we say about like Hispanic women are that we're very dramatic, right? And so you'll hear, oh, they're just being dramatic when it comes to pain, right? Well, that's a problem because it's not for you to judge if I'm being dramatic, right? Like if I'm in pain, I'm in pain, right? But that's something that we say joking, but it plants the seed in your head, right? And so even though you're joking about it,
stereotype, right?
Right. Then you see it and you're like, and you keep it moving.
And it's a double standard, Jessica, because you're a woman too, and we know that women are also judged by their gender. And I'm working on a written piece right now about that double standard. How I'm a sexual medicine specialist, so I'm writing a chapter of something about how Viagra was rushed through the FDA for emergency use because it was this world-changing medication to help men. But the first FDA-approved medication for female sexual function, oh my God, it was a decade of hurdles and jumps and male committees saying, women don't have sexual problems. Why are they complaining? They're just complaining, So when you're a female, you're already getting judged not by the color of your skin, but by your chromosome, right?
Well, it's both, right? And just to piggyback off the stereotype, so for Black women, if you serve as an advocate for yourself, if you ask a lot of questions, if you are, you stand up for yourself, then you're the angry Black woman. And then all of a sudden you're a difficult patient. And then all of a sudden you're not getting the same type of care because everyone's avoiding your room because you're asking too many questions and you're demanding things that they feel as though you shouldn't be demanding. And I think, and I can't. I'm sorry that I can't remember the physician's name, but there was a Black physician who recently died of COVID, who was actually videotaping and on Twitter putting her story up about how she was treated at a hospital as a physician, as a Black woman, and they kept dismissing her needs, kept dismissing her pain. They discharged her twice, and she eventually died. But she actually was documenting the level of care that she was receiving, regardless of the fact that she was a physician, because she was asking questions and demanding things and arguing, not really arguing, but asking questions that were questioning the type of care she was getting. And again, she was seen as a different patient. Dismissed. Yeah. So it absolutely, permeates for, like you said, not just women, but, women of color.
Right. It's a double whammy. It's a double whammy. Yeah. On a previous episode of Gynecollege, I interviewed the founder of a foundation called the FH Foundation, the Familial Hyperlipidemia Foundation, which is basically genetic high cholesterol, which I have personally, and the founder also has. And she's a beautiful, blonde-haired, big-tooth, attractive, thin woman. She looks like the picture of health. And she had a heart attack at 35, and she called 911. And even as they were lifting her into the ambulance, the EMTs were telling her, don't worry, you're just having a stomach upset, or you look way too young and healthy to have a heart problem. You couldn't possibly. They didn't even want to do the EKG in the ambulance because they said you're being dramatic to her. Yeah. And of course, she really did have advanced heart disease with multi-vessel disease. But they judged her on, age, and her weight was perfect and everything. And then they kept saying, you're a woman, you're going to be fine. You have all this estrogen to protect you. And it was maddening to her. And we talk about that on a previous episode. But what we're talking about is really, I think, almost the double layer of being a Black woman or a Latino woman and saying, oh, you're just hysterical, or you're the troublemaker, or so how can we tell our patients, what can we tell them though? How do you tell them to advocate and to help themselves be taken seriously? I mean, this is hard. I don't know that I have the answer to this, by the way.
Yeah, I mean, look, when I did primary care, I would always tell patients, you have to connect to your physician, right? And that's just, if you don't like me, you should not see me. Especially for the person that's going to take care of you, from a general perspective, right? Because I have to be your advocate. And we have to be able to trust each other and develop that relationship with one another. That's easy for elective things, but I think when you are talking about being in a situation where it's more emergent, or you don't really have control of who it is that you're seeing, I do think that you have to ask questions, and we owe it to you to answer those questions. I tell patients to take a paper and pen, write down the name of everyone that you're seeing, and not from the perspective of like, what's your name? I need to know, but from the perspective of, oh, can I have your name, right? Because once you start making that connection with someone, they know that you know who they are, and vice versa, not in a punitive way, but from a perspective of, can you connect with the other person on the other side of you in a more as a person? And
Right.
Because I think that as physicians, we are humans, it becomes really important for us to make some type of connection, because then some of your biases come down, right? And once you start to see that person as someone that you can identify in some capacity with, then it's not a Black woman. It's not the angry Black woman in a bed. It's not the hysterical Puerto Rican woman screaming for pain. It's the person that has, 2 kids at home or 3 kids at home. And so I try to connect with patients for myself, but I think it's equally important for a patient to try to find some type of connection with the doctor, because then it humanizes the patient to the doctor. And we all, like, we get used to, we see things every day. So what is scary to a patient, to us is like, it's just chest pain. They're gonna work it up. They're gonna move on one way or another. But trying to put a person, their story, to them will allow the physician, I think, to want to advocate for you. And then if that doesn't work, you have every right to ask for someone else. You have every right to keep asking questions, and to advocate for yourself, because no one else is going to advocate for you. We like to think otherwise, but hospitals and the health system in this country is inherently unsafe, right? And we work to create safety practices. But until that is really worked through, I think it's important to be your own advocate and to have someone in the room with you. I do think when you're in a hospital, or when you are, if you're a patient, and it was hard during COVID, but it becomes really important to have someone there with you, have someone help kind of navigate the system for you.
So to just say, to restate that very succinctly, it's really a two-way street. If you as a clinician can show a little bit of your soft underbelly, or bond, or find something in common, or just get to know something about your patient as a human, not just as patient number 12 that day, it both serves to connect you to the patient, and I think it shows a little empathy and a little vulnerability, and it takes you off that pedestal as a clinician. And then I think sometimes they appreciate that. Anyway, I agree 1,000%.
Yes, so do I. I think that personal connection is important, but I think it also speaks to how it's important for us to increase diversity in healthcare, right?
Yep.
Although every patient doesn't have to have a race concordant provider, I think studies have shown that when there is, when the patient and a provider are of the same culture or race, that decision-making, patients are more involved in decision-making. They discuss the social determinants of health more often. They discuss psychosocial and emotional issues. And so I think, and so all of those things are important in helping patients feel to have a little bit more autonomy. I think the conversations are more balanced, but that level of a connection with the provider, and I think they're more empowered to be able to ask those questions and advocate for themselves.
Yeah, I remember it must have been I think I was a medical student on my clerkships, and I was listening to a doctor counsel, diabetic after diabetic for minorities, mostly Caribbean minorities. And they kept saying, you have to cut out all of the rice in your diet, right? If you're Caribbean, it's like not possible.
You can't, right.
And so he would say, you can have as many beans as you want, but just take the rice out. And, at one point I remember I pulled him aside. He was Dr. I won't say his name, but I remember I pulled him aside. I said, you do realize that like, we can't eat rice we can't eat beans without the rice. I feel like you have to change your strategy here a little bit. Maybe like you can try for brown rice, but even that is a stretch. So, but because if you don't have that cultural competency to understand what you're asking the other person to do, they're just not going to do it, right? It's not.
Right. And vice versa, patients are going to feel more comfortable saying to you, I can't cut the rice out. Give me something else. If they feel you understand.
Correct. Right.
And we've all have different statistics, but we know that both Black and Latino women are underrepresented as physicians in the United States today, and so that is certainly one other place where we can do better, is to be able to have our, the representation in our medical schools reflect the needs of the patients. Easier said than done,
There was a question, right, Doctor?
Yeah.
There was I saw a question somewhere about
it was what you both felt about COVID vaccine in minorities.
You want to take it, Africa? Right.
Sure, you can start.
Oh, I mean, look,
you said, do I want to take it?
Sorry. Yeah, I can start when,
I did not hear the question.
Oh, the question is just about our view on vaccine. I only asked because I've talked to you about your views on vaccines. Look, when it first came out, we were talking about a vaccine. My husband and I were both like, I don't know. But let me tell you, the second it came out, we were like, forget it. We just need to get it. I think what is alarming is that even though we represent the majority of patients with COVID, and we have worse outcomes than our white counterparts, our lack of trust in the system, we're seeing that play out, right? We're seeing the history of how we got to where we are that made us have these outcomes. Really, the history of how healthcare interfaced with minorities in general, but Blacks in particular. We're seeing that mistrust play out, and it's sad that they don't trust the information they're getting. The information that they're getting is vastly inaccurate. I try to have pods of conversations with anyone that I can to help them understand what this really is. But sadly, until they see that more people are getting it, they don't really trust it. And, I want nothing more than for that. I almost felt like we should have been able to, because we were getting it more, give more to that population to protect them more. But even when we did, they won't accept it. So if we could do anything to get people to get vaccinated and see that, we were all vaccinated, it's not true. We're not going to get COVID from the vaccine. Really being able to put out accurate information.
Yeah. I mean, I think that even in my own family, I have to have conversations about, the mistrust in the vaccine and, and even in the healthcare system. And I'm a physician. And so it's real. It's not just other Black people. It's real. I have to deal with it with my own family. And I think the fears are real. I think it's our responsibility now to show and not just say that the healthcare system is different. But I think if that trust has to be earned again, and it has to be earned not only in words, but in deeds. And I can't say that we've done that yet, right? And so it's a little bit unfair to, just because this is a pandemic, to say, hey, we need you to forget about all the things that happen. We need you to get this vaccine, without huge efforts in trying to maintain, to recreate that bond and get that trust again.
So let me ask you a question, both of you. What are you hearing is the most common reason why minority women don't want the vaccine? What is, maybe if we can understand what the number 1, 2, and 3 stumbling blocks and fears are, we could break those down tonight before we close out, so that at least There is an episode of Gynecollege on vaccine myths and
Yeah.
frequently asked questions, and we can put a banner up so women can go to that episode. They can go on YouTube and find it. My guest is an infectious disease specialist and the head of vaccine policy at Princeton Health Center. So there's the link right there. But and there's great info on that. But when I have a patient, I had a patient last week, and she said she lost her father and her son to COVID. Her 23-year-old son, and who was obese and asthmatic, and then her, I want to say, 75-year-old father. So this is a woman who's had tremendous personal loss. And I said, please, and I didn't word it well. I wasn't very proud of how I said it, but it just came out. I was so moved by her loss. I said, please tell me you're considering getting the vaccine. And she said, well, I think I better wait a year or so to make sure there's nothing wrong with it. And she said, it's just too new. Not enough people have gotten it. And I couldn't help myself. I said, ma'am, actually, millions of people have gotten it now. So I said, if this were a study and we had millions of people in a study, that would be considered an incredible study. So I said, we've gone in just a few months to the ability to have millions of people show us that they get this vaccine and they don't die from the vaccine. And she said, well, I guess you're right. Maybe I should think about doing it sooner rather than later. Because she said, everyone around me is getting COVID. So what do you guys see? What do you feel, or what do you hear are the stumbling blocks, are the reasons for no? And what could be a thoughtful answer we could give as clinicians to help turn that way of thinking?
Yeah, I mean, I think the biggest one for women, especially women of childbearing age, there's the questions about what is it going to do to their fertility.
Right.
Fair. I had this kind of impromptu conversation where I just pulled people together. I just pulled a group of people together to start asking these questions. And what I was surprised to hear was that they really do believe that the government has done something to the vaccine, right? Especially the first ones that came out was mRNA. And so it was this kind of wacky thing that we've created, and the government has done something to it to then infuse into the body of people, whether it be tracking devices or some type of thing that's going to harm them. And, I was taken aback because this isn't, in my head I guess my own bias was that if you were educated, you wouldn't think that. But I had to really, I think, check myself because I think there are a lot of educated people that do believe that. But in fairness to them, I had to really think hard about how did they come to think that way, right? So in fairness to them, that is not so crazy based on things that have happened in the past, right? And so in hearing that rationale of thinking, I said, so I guess, but in a way, because most of the people that are getting vaccinated are actually white, so we actually did the test on the white population. So now you can get it. But, I think that if you have to understand where something is coming from to really, instead of just saying, well, that's dumb, you shouldn't believe that. I think that we have to put validity to the fact that that it's real, right? That their assumptions
and their fears are based on
reality,
are valid.
Right,
if you look at
Correct.
things that have been done and done to them, and whether it's Tuskegee or Henrietta Lacks or all Crow. I mean, you could go for an hour, but what I say to that, and again, I say it because I don't. Perhaps it shows a lack of empathy on my part. I'm not sure, but what I say is that yes, but white people are getting the vaccine. So if white people are getting the vaccine and there's some harm in it, it's just harming white people as well. And so
right. That was what I said. That was my response.
Apart a little bit. What did I miss?
No, that was my response. It was like, but all the white people got it first, so you should be okay now.
Right. Well,
please, but.
I know, because I'm not in primary care and I'm pretty super specialized, I really don't have those conversations that often.
Your patients are all asleep.
Right. Exactly. They're asleep.
Mm.
So like I said, it's usually really on a personal level.
Yeah.
I think, in order to, like you said, in all fairness to them, I think people are being so bombarded by information from the internet, and they have access to good information and perhaps more bad information and good information. It would be hard for even it's hard for even educated people to
Sift through it.
decipher what's right, what's true, what to believe. Things are so polarized these days that it really doesn't matter whether or not it makes sense. It just matters if that's the side you're on, right?
Yeah.
And so I think it's going to be an uphill battle, but I think continuing to have those conversations is what's important. Each person that you talk to, you may just change that one person's mind.
Right.
Once in a while, I may have that conversation in my office, and I'll have them walk out and say, you know what, I might think about it. That's all that's about the most I can ask for at that point, that you'll think about it. Or, as I have my family Zoom call, I remember earlier in the year or late in the year when we were talking about it, it's about 15 of us every Sunday. Nobody raised their hand except me.
Oh man, you have your work cut out for you.
They were going to get it, but I'm proud to say that more than half of us have it now. And so, because we continue to talk about it, everybody gets to voice their opinion. Definitely the older people have it, and I'm really happy about that. But it really just comes down to continuing to have those conversations in a meaningful way.
Right. Well, as the OBGYN in the room, I'll just do a plug for vaccination for women who are considering childbearing. The American College of OBGYN, it's not that they say everyone should get vaccinated. I mean, they don't want to take that radical stance. But what they do know and feel quite certain about is that COVID in pregnant women is a more dangerous disease. And because of the anatomic and physiologic changes that happen in pregnancy, pregnant women who get COVID don't do as well as their non-pregnant counterparts. So if you are thinking of getting pregnant, you are helping make your pregnancy more safe by getting COVID vaccinated. It's one of the things you can do to ensure a more safe pregnancy for yourself. Second point is that the children born, the babies born to vaccinated women often have antibodies to COVID. So you are getting, free vaccination for your newborn, which again scares some people, but I view it as, if my baby is born with antibodies, that is one less disease I have to worry about for that baby. And then the third point is about the vaccine itself and how could it really be harmful to your ability to get pregnant. This is a myth that started in Germany, where a German scientist found some genetic base pairing that mimicked something in the placenta. Completely irrelevant, but like Whisper Down the Lane, that turned into fear of somehow effects on pregnancy. It has no effect on pregnancy, zero. It doesn't matter what age, race, religion, sexual orientation, or what basketball team you're rooting for. It just doesn't matter. The vaccine has mRNA that's injected into the body. The mRNA cannot and does not go into any human cell, including the ovarian cells that ultimately become eggs that are fertilized. It doesn't go there. It doesn't change the DNA of those cells. So it really can't have an effect, even if it wanted to. And it certainly can't have an effect on one race and not another. But I'm saying this more for all women of childbearing age, or if you're a woman who has a daughter of childbearing age who says, I'll wait till after I have the baby to have the vaccine, that woman's doing herself and the baby a disservice, I think. So obviously I'm not very shy about that, but I feel so strongly about it because of course we have to vaccinate our elderly, and of course the immunocompromised and the patients with comorbidities. But the healthy young women who want to have children in the near future, they're people who may end up in an ICU on a ventilator, and they don't need to. They just don't need to. So, all right, I'll get off my OBGYN pedestal now. But do you have any last points or thoughts before we wrap this up? I don't want to keep you guys too long. You're so busy, and I really am so grateful that you took the time to chat with me and to share your thoughts with the women who are listening.
I mean, my last remark would be that these conversations are critical for us to be able to unravel the mess that we have found ourselves in. And, you know, as I said to you in the very beginning, I think it really does need to start with people like you, and it has to come with all of us saying, what can I do personally different so that I can change what's really happening? And that, you know, everything starts from the very first steps, right? And so we've got to take what came to us and was a horrible thing to hit us, and say, you know what, maybe the one thing that could be good of this is that we spent more time with our families, and that it really highlighted inequities in our whole system.
Yeah.
Right. And that those inequities stemmed from systemic bias and systemic racism and the infrastructures that we have in place. And if we can do anything, read an article, read something that makes you open your mind to that you may not know what you think you know. Right. And it starts from there, right? We grow a little bit more and more every time we read something different. Watch something, pick up, look at something on YouTube, find something that makes you think to yourself, wait a minute, could that be me? Because those are our first steps.
And we are so polarized. I mean, watch something different, I would say too. I know people who they always get their news source from the same social media channel or the same news outlet.
That's right.
And you may not agree with what you watch, you may not like what you hear, but watch something different. If nothing else, it tells you about what other people are thinking and reading. I do want to say two things. One is that there is something local that the three of us at least should know about. On May the 6th, the Princeton Area Community Foundation has a fund for women and girls, a luncheon 2021. And the topic this year is health equity, the pandemic, and the next normal. So I think this is something you could certainly Google search and try to see what that is, but that would be something neat to watch. And learn from, and again, similar topics. So that's right in our backyard. And the other thing, I guess, is that just to keep watching episodes of Gynecollege, because we tend to have thought-provoking topics. The next episode is on April 15th. They're always Thursday nights, and we have a really lovely guest, Dr. Ann Steiner from Penn, who was named a couple of years ago the National Gynecologist of the Year. She's actually warm and empathetic and so progressive. And she'll talk to us about hormone replacement therapy. Dr. Wallace, thank you so much for making the time to be with us. Dr. Codjoe, thank you so much. I know you're busy with your lives and your careers and helping the patients who cherish what you do, not to mention your own families. So thank you so much. Really appreciate it.
Thanks for having me.
Yep, thank you.
Thank you. All right, good night. Until the 15th.
Good night.
See you later. Take care.
All right. Bye-bye.
Bye.